One sunny day in 2014, I was riding the New York City subway back from the Children's Hospital at Montefiore, where I was working as an attending in the pediatric complex care group. Our group of pediatricians, nurses, social workers, and care coordinators supported children with severe medical conditions. Only children facing a severe, life-limiting condition such as an organ transplant, congenital heart disease, or chronic respiratory failure requiring long-term use of a breathing tube or ventilator could qualify for the program. We also accepted children who had two less severe medical conditions. We wouldn't take a child with just inflammatory bowel disease or just cerebral palsy, but if your child had both, it was likely that they would need our support. For the family's convenience and continuity of care, we also took care of these children's siblings. This day had been a tough day in a tough week, and a hospitalized patient was not improving. Her underlying genetic disorder and associated medical comorbidities had led to malnourishment. Her poor nutrition had led her to have difficulty with the healing of the skin surrounding her feeding tube. Her feeding tube troubles were worsening her malnutrition, and she had just gotten a cold, limiting our ability to do much of anything until her fever subsided and her need for supplemental oxygen decreased. At an hour-long meeting in which I worked with her family to help coordinate her care, there had been raised voices and tears as they grappled to understand why this was happening, why now, and how to make the best plan with conflicting input from the surgeons, nutritionists, gastroenterologists, and others involved in the case. A new field. The field of complex care pediatrics is relatively small and growing. Its objective is to bring families the support they need through a variety of models. In our model of care at the Children's Hospital, we took on the full primary care role for these chronically ill children and their healthy siblings. We had pediatricians who offered longer visits, and we also provided more nursing, social work, and nutrition assistance in advocating for these families. These resources allowed us to provide continuity of care when our patients were in the hospital or emergency room, which happened often, to support finding appropriate school environments, to ensure their homes were well-equipped and accessible, and to provide routine primary care in the clinic. Other models of complex care may work differently. In more rural areas, complex care pediatricians often help in a consultative role, supporting pediatricians in developing an annual care plan. Some states offer care coordination programs with nursing or social work resources through insurance or Medicaid plans. Working in complex care many days has the same feel as being a regular pediatrician. I work to support children and families. Sometimes the stakes are higher and more intense and the conditions more complex. But despite carrying more diagnoses or having more healthcare needs, at the end of the day, it's still about helping children and their families. One bright side of the increased frequency of visits is that as the pediatrician, I have the opportunity to get to know the family better. On average, the children in my practice came to my office around 4 to 8 times a year, and I saw them through 1 to 2 hospital stays in addition. Because of the time we spent together and the privilege of getting to really know the patients in my care, these families taught me much of what I know as a pediatrician about what it's like to face a challenge. On particularly difficult days, I appreciated having time to decompress and process the day on the way home from work. This day, I sat on the subway, scrolling through social media and rethinking my work with this family and how I could do more to help them, when a friend from my neighborhood called. At just age 2, her son had been diagnosed with asthma after several colds involving extreme wheezing. She was struggling to understand why this was happening, why now, and how to make the best plan with input from her husband, mother-in-law, pediatrician, and new pulmonologist. My first thought was that mild asthma is easy compared to what I do day to day with really sick kids. Still, as I talked through things with her, I could not ignore the similarities in these families' struggles. These children were in wildly different places. One was hospitalized and threatened with admission to the ICU, and the other was at the playground. Each experienced entirely unrelated problems, one with a genetic diagnosis and one more likely triggered by environmental factors, and yet the parents were coping with similar stress. How could they process their situation, make sense of it, and move forward? I knew I could help them both. I could help them understand and research what they faced, find resources that they needed to make decisions with confidence, and put together a team approach to be proactive and preventative in the future with their child's health. But at the same time, I thought, this work does not fit within a 15-minute visit or a message sent through a healthcare portal. I wondered why the systems weren't set up to better support these families. Parenting is hard. Because we care so deeply for our children, as parents, we want things to be perfect. As a parent, you want things to go as planned. You want to be prepared for every developmental change and anticipate your child's needs to properly support them. But parenting is even harder when things do not follow a typical trajectory.